I'm super excited to introduce my friend Kate Newman. She's the Director of Experiential Education and Clinical Associate Professor for Pharmacy Practice at SIUE. Her research interests include professional development of students and preceptors, the scholarship of teaching and learning, and enhancing student, faculty, and preceptor well-being. So without further ado, I'm happy to turn things over to Kate.
Thanks, Heather. Those introductions always feel a little like unnerving for whatever reason when you're listing all the things you work on. But this is something that I feel really passionate about, and I've been talking about a lot over the last couple of years. So I'm excited to have an opportunity to share kind of what I've learned in our student group, and then hopefully we'll have some time for some dialogue and to hear your perspectives and maybe things that have worked for you or questions you might have as well. So I'm going to do my best to stay kind of on track with time here. I do have the chat open too, so if you have questions throughout and you want to drop them in the chat or anything like that, feel free to do that, and I'll try to keep an eye on that. But Dominic and Heather, feel free to interrupt me too if there's something I need. Okay. So as Heather said, I work at Experiential. I've been working in Experiential since 2013. Prior to that, I was a preceptor, and my clinical interests when I was in a more traditional role were outpatient, AmCare, and psych as well. And so I think my love of mental health has probably bled into these topics where now a lot of my interest is focusing on well-being of students and preceptors and learners and kind of everyone in the group. So today we're going to talk about supporting learners through distressing events. And I'm going to talk about students and APPEs and learners, but this could definitely be applied to colleagues. And we'll talk about kind of the power dynamic of students and learners, and new employees sometimes fall into a similar dynamic. So this could apply to residents and other folks as well. So I just want to bring that up at the beginning. So my goal for today is to talk about kind of these big three items. We're going to talk about work-related trauma, and that's a technical term. You'll see we talk about distressing events kind of in the slightly different lens, but we're going to talk about what that means. I want to share a little bit about what I've learned about frequency of student experiences with distressing events during APPEs. And then hopefully we can talk about some practical ways that we can address it. And we'll talk about there's some limitations in what we actually know works, but we're borrowing some strategies, and then hopefully we'll have an opportunity to learn from each other as well. So just to start with that main term, work-related trauma, this is a term that's used extensively in nursing and medical literature, as well as some of our other health profession colleagues. And basically, it's a term used to describe exposure to a traumatic event within the workplace. You know, I think we all probably understand that healthcare workers experience lots of traumatic events as part of their everyday work. We are not strangers to patient suffering, death and dying, all sorts of difficult experiences that are just part of the work we do. But that doesn't mean it can't have a lasting impact on someone. And so that's kind of that framework that we're talking about. So experiencing something traumatic within your work and kind of what impact that may have on us. Now I mentioned it's very well described in nursing and medical literature, but interestingly, there's nothing out there on pharmacy. So we don't really know for sure the impact on pharmacists, or we haven't. Yet we work in those same environments, right, as many other professions. So it doesn't seem like a stretch to assume that we're in similar situations. Just to give a little more background of work-related trauma, again, this is coming from the literature, but there's lots of different ways we can think about how you might categorize types of events or experiences. For those of us in healthcare, you probably, when you think about that term, you may have an example of something from your own experience that already comes to mind, something that really stuck with you. But we can broadly categorize traumatic experiences into one of these four buckets at least. So we've got our patient care related all the way on the left. This is the stuff we probably think of most when we think of healthcare. So like I said, death and dying, medication errors, serious illness, maybe even witnessing a patient who is mistreated, or maybe we feel like they aren't getting the appropriate treatment, and that may have an impact on us. Personal conflict. So this might be harassment, bullying, or difficult power dynamics within the work environment. So that might be our personnel disagreements there. There's hazardous exposures. You can think of this as exposure to hazardous materials. And so the COVID pandemic is a good example of this. There's a lot of literature coming out now about the impact of being exposed to COVID on people's well-being and their personal experiences, not just their physical health, but it could be hazardous other exposures. This could also be potentially workplace violence, is also another type of hazardous exposure that may occur in healthcare. In some settings, it is more common than others, but that could be something we're thinking about. And then in 2020, there was a new study that came out in nursing that actually defined this new category called insufficient resources. And I always like to bring this up because I think a lot of us are dealing with difficulty in staffing and where we work. And this, I think, is coming up more and more. But this is that challenge that folks may face when they don't have enough staff to appropriately care for their patients or enough resources. And if there's poor patient outcomes as a result of that, that experience can again create kind of this lasting distress for someone potentially in work-related trauma. So when we think about all the different things that can happen in our workplace, I think it's helpful to think about categorizing them into things that are avoidable or preventable and things that are not. So when we think about, serious illness, that is not a preventable thing that we can not be exposed to as healthcare providers, right? That's part of our work, and it's something that's going to be a part of what we deal with. Where harassment, maybe there are ways we can think about preventing that. So we're going to talk about the difference between the two, but I think it's an interesting framework just to keep in mind. And how we approach the situation may vary based on what kind of trauma it is. Students have a unique lens that work-related trauma can impact them a little bit differently. And there's a couple of main points I want to bring up. One is that students are often underprepared for what they're about to experience in terms of the emotional component of being a healthcare provider. When we study students, they often underestimate how frequently they're going to be exposed to distressing events. So it happens more than they think. And they overestimate how prepared they are. So if you ask students before going in, many of them feel more confident in their ability to emotionally cope with that than what really ends up happening when they're experiencing it. So I think this is a textbook example of learning something in a classroom feels very different than being there at the patient's bedside or in that experience. So I think that just kind of highlights that difference. Additionally, there's some extra challenges. Students don't have as much control over a situation or even a response. They might be making recommendations to a healthcare team, but ultimately that decision is going to be with those healthcare providers. So students might feel a little bit like they don't have control to impact a situation. There's a power dynamic, of course, right? Students are being assessed and evaluated, and they're getting feedback on their performance, which is an important part of experiential learning, but it can create a power dynamic. And there's also some literature to talk about our student learners, and they tend to be mistreated at a higher rate compared to colleagues in the field. So I think these are important just to kind of keep in mind that these are some of those situations that can increase that distress potentially for a student. I also want to point out that there's probably a continuum here, right? We can have a distressing experience and it's distressing in the moment and it doesn't impact us later, all the way up to having severe lasting consequences. But it's important to know that there can be really severe impact of traumatic events. Again, this is coming from our colleagues mostly in nursing and in medicine. Some of the things we know are that likely your first experiences with a distressing thing might be the most impactful, or it's that experience that you remember on and on and on, and it's the situation that you keep calling back to mind. I know personally I feel that way. I can remember the first code that I ever attended. I can remember some of those other events that are kind of emotionally impactful more than I remember the subsequent experiences. So that first experience can really be intense first. And when we think about students, many of them are having those first experiences during their rotations or early in their career. And exposure to work-related trauma is correlated with increased prevalence of PTSD in those individuals. There's obviously other outcomes that can come from this too, but again, I just want to point out that something that maybe doesn't always feel like a big deal can have a very real consequence on individuals. The other thing that's interesting that we can learn from our colleagues is that folks who have distressing experiences want to talk about it. It's kind of one of the things we know best about this work-related trauma experience is that debriefings and conversations about what happened can be really helpful for individuals to kind of go through that. But we know that that's not happening universally. So literature says, yes, it's really helpful. This is something we can do after a distressing event, but it's not always occurring. There's lots of reasons why that might be. Just we are unaware that they're happening at all. But also in the medical community, there is sometimes this maybe not tolerance for emotional response, or I'm supposed to be the polished professional in this situation, like I'm not going to react. And sometimes that can also be disconcerting for students who are experiencing, or other individuals. I feel very distressed and no one around me is showing a reaction to that. That can kind of sometimes lead to this, like, am I supposed to not feel, or what am I supposed to feel, or how do I do that? And so that debriefing can be a time at a more appropriate point in time, often for a team to come together and talk about how they're feeling, what that was like, what they're, what the next steps might be. So I mentioned we haven't studied this in pharmacy up until now, at least not in the published literature that we can find. And so because of that, our institution, we partnered with another public Midwestern School of Pharmacy to do a study. And we don't have this published yet. We're still in the process of writing the paper, but I want to share with you our findings just to give you a sense of kind of what we have found in our pharmacy students. The things we were asking ourselves were, how frequently is this happening in our APPE students? And are they being addressed after the event? We did ask them some questions about impact and lasting impact and some other items as well, but those were kind of the two big things we wanted to understand. So we surveyed our APPE students at the end of every semester and asked them to report out, did you have distressing events or not? Kind of what rotations were you on, and collect that data. So I'm going to give you kind of a look at what we found. We did this over the 2021 to 22 academic year, and we had 148 student responses. I will note our response rate was 28%, so it's still a low survey response rate. This was completely optional. So I do think we have to remember when we're looking at these numbers, like this is a small percentage. However, we found that 64.4% of students experienced at least one distressing event in the year. And I know for me, seeing a number like 64% felt very concerning. Like that was a very high number. If we assume all of our non-respondents didn't experience an event, we're still looking at about 18% of our population. So likely somewhere, but at least 1 in 5 students, all the way up to much more than that, who are experiencing distressing events during that APPE year. And those results were very similar between the two schools. So proportionately, they looked like similar rates. We asked them about some specific categories, and this was based on a study in medical students. That's how we came up with our categories. So we asked about patient care related, so things like death and dying, attending codes, medical errors, those kinds of things. Student provider conflict, so that could either be a student conflict with another healthcare professional or their preceptor. Seeing patient mistreatment was the third category. And then we had an other category where if they felt like it didn't fit into this, they could choose that, and then they could describe more about it if they wanted to. So you'll see what we found was most of our responses were coming out of the patient care. That was our most common category. But student provider was also fairly high with 44 of our total responses. We also looked at this by rotation type. And so in this graph across the bottom, you can see general categories. Now, this is how we categorize our rotation, so it might look a little bit different, but ambulatory care, community, elective. NPC stands for non-patient care, so non-patient care directed electives, patient care electives, hospital rotations in internal medicine or general medicine, acute care. I feel like that one gets a lot of terms in different schools, so that's kind of how we're defining it here. And the different color bars show the different types of experiences students had on those rotations. So our hospital and our internal medicine, or our traditional inpatient settings, had the most distressing events. And I think that maybe isn't uncommon when you think about serious medical complications, patients not doing well or whatever that might be. But I think it's important to note that every rotation type had some. There was no setting where this was, we're immune from this. And so the types of rotations may look a little bit different, but it was across settings. Even in our non-patient care electives, we still found some patient care related experiences. So it may not be firsthand. It could be something that has happened to someone that maybe they don't have a personal connection with, but they're still impacting them. So that's what I want to point out here. Again, we asked students a little bit about impact. What kind of lasting impacts did they identify? Or maybe they said none, and that obviously was part of that too. But 44.8% of that 64% that experienced an event said, I had a lasting impact from this. And again, this is their subjective personal experience. But again, I think that it's valuable to understand that. So we used some of the PTSD criteria when we were creating our survey. It certainly is not diagnosing PTSD in any stretch, but these were the things that came up most frequently. So recurrent or intrusive memories, dreams and flashbacks of those experiences beyond when they occurred. When we asked them, did anyone talk to you about this after it happened? Did you debrief or discuss? Only 35.3% of students said there was any discussion of this after the event. And so again, for us, that was kind of an alarming statistic to say this is happening more often than maybe we imagined. And it's not getting discussed, which is the thing we know is most helpful for students. We had some open-ended comments too, and I put a few quotes in here just to share, to kind of give a perspective of students' experiences. But a lot of students said, like, I just didn't know where to go. Either my preceptor wasn't available to me, or they were part of the scenario, so I didn't feel comfortable debriefing with them, or maybe they weren't there, so they didn't know what happened, and then they weren't sure if they should discuss it or not. But then there's some, I think, moving open-ended quotes, they just saying, I needed a break. Like I needed time to process what happened, but I had to go counsel patients right after. There were comments about, again, student experiencing bias or microaggressions towards them, and saying it's really difficult to get through a rotation and learn when people are viewing you as an outsider. Students saying, I wasn't expecting it or I hadn't seen it before. This last comment, I think, also is powerful, saying, I didn't want to burn a bridge, so I didn't bring it up to anyone. And I think, I know at our program, we definitely tell students all the time, pharmacy is a small world and you never know who knows who. And I that's important, but I also think that sometimes they take that and then they kind of shut down a little bit because they're not sure where to go, or, they don't want to harm their futures either. So these were some of our findings. Again, small sample size, 2-program cohort, but I wouldn't be surprised to see similar results. I will say our numbers that we found, that 64%, were right in line with what the medical literature students are showing. So very similar to what other disciplines who work in medical fields see. So again, it's a grain of salt when we look at small pieces of data, but it's some data to look at instead of what we had before, which was really, we didn't know. So when we talk about what do we do? Like, okay, we know what's happening. We know it maybe isn't being discussed at the rates we hope. Like, how do we deal with this? Again, I come back to that avoidable and unavoidable circumstances. I think we can't avoid, right? We said that patient care, a lot of those patient care related things, nor are we trying to. I don't think it does our students, good to shelter them from experiences that are part of being a healthcare provider. Like that's part of it. And so I don't want to imply that we're trying to just bubble wrap our students and never have them experience anything difficult. But I do think it's helpful for us to think about if there's avoidable circumstances that shouldn't happen at all, like how are we addressing those at our sites proactively? And for the things that are unavoidable, how are we responding to them? So we've kind of, talked a lot with preceptors over the last couple of years since we did this data, and have kind of landed on what we think has maybe been most helpful. So kind of thinking of how we approach this in 3 buckets. So how do we prevent things that are preventable? How do we prepare both ourselves and our students for what they're going to experience? And how do we respond after something has happened? And so just to give some like practical things that maybe could be helpful, and then I'll open it up too for questions and feedback in your comments. But when we think about prevention, again, reflect on the culture of where you are and in your setting and your site. Try to not practice those avoidance and enabling behaviors. So some things that I have heard definitely kind of in healthcare, like, oh, that's just how that person is, like that, yeah, we all know they're terrible. But if we're sending our student with that person and maybe we're not there, there's not anyone else there to help manage or buffer that, like, is that a good learning experience for students, or do we need to figure out how to address those issues? Or, sometimes students get told, like, just ignore anything that person says, like, don't worry about them. And again, like, is that who we want our students to be learning from? And students have that power dynamic. They might not be able to just ignore that person, or they're worried about assessment or feedback or burning the bridges. So again, thinking about the culture, again, it's not just the preceptor, but it's everyone they're interacting with. And so trying to practice our conflict resolution strategies instead of avoiding or shying away from colleagues who maybe we know might be, you know, difficult in some circumstances, like thinking about that proactively again before we're bringing students in, but also for the well-being of everyone in that environment. It's also good to know your policies and procedures for where you are and how those things would be addressed. How is bullying and harassment addressed at your hospital or at your institution? Do you feel prepared as a preceptor to address those things in the way they need to be? Of course, your experiential folks are going to have all sorts of policies and help too. So I'm going to always chime in, like, reach out to them if something comes up and you're not sure what to do, but understanding the policies at your site can be helpful too. And then remembering, are we creating an environment that will allow students to disclose their concerns, both to you as the preceptor in the site, but I also think about this in my office as well. That 30% of students who were debriefed, that other 70% or 65%, did the preceptor know that thing happened and that they felt distressed by it? Like, they may not have, and maybe things would have been different had it been disclosed to them. But have you created an environment where they understand, that they can do that? I think that tips into our prepare bucket too. So I think it's valuable for you as a preceptor to reflect on your rotation experience and think about, is it likely that a student will experience a distressing event? Like, will they be exposed to something that could potentially be distressing? And I also want to point out here, we all have our own unique experiences. We can experience the exact same event and it might be distressing to me and not to you, or vice versa. You all likely have lots more experience with this than your students do. So something that doesn't feel distressing to you now might have felt distressing the first time you experienced it, and we've just not, our coping strategies have changed. A team's coping strategies might be really healthy and wonderful, and maybe they're not. I certainly wasn't taught actual coping strategies as a student or a young practitioner. I think I was kind of thrown in the deep end. And from folks I've talked to, I think that's not uncommon. And we'll hear from our colleagues in critical care that say, yeah, sometimes we use humor in our team as a way to cope, and that works great for the team who knows each other really well, but a student coming in, that might feel really jarring to them. And so again, thinking about your own experience and the culture of your team, not saying that team needs a new coping strategy, but you may just need to prepare the learner for what they're going to experience before it happens. And so that comes to this proactive conversation. I think it's really valuable, and students said this in their feedback too. I just wish someone would have warned me about what was going to happen, or it would have been really valuable to understand this is how the team is going to discuss this, or this is how I can approach my preceptor if something has happened. But if you can set that up in your orientation to your experience in those first couple of days with your students, you're already laying that groundwork to have a conversation when something occurs. Again, there are unavoidable things that will come up. And I think it's okay to tell students, like, hey, this experience, you may see these types of events. I'd be glad to talk to you about it when that happens. Or if it's applicable and you're open to sharing your own experience, a lot of students do appreciate hearing, like, I know this can be really difficult to process right now. I've had a lot of time to process it. And so that's maybe why my reaction looks a little bit different than yours. I think normalizing with students, it's okay to feel as a healthcare provider. It's okay to feel scared. It's okay to feel sad. It's okay to feel this is really difficult. But normalizing that with students when they're at the beginning of their experience with that can be really powerful. And if it's a situation you've proactively talked to your student and you know there are some things that it might be really difficult for them, or some situations that might be difficult, if you can help them with an exit plan to get out of that situation if they're feeling overwhelmed or if they need to take a break, I think making that exit plan up front is great. So, before going on round saying, hey, if you ever feel really overwhelmed and you need to just take a minute, check in with me and let me know. But it's okay to go take a breather and then come rejoin rounds, rather than the rapid pace. Or like the student who said, I just needed a break before I went to go counsel a student or counsel a patient, setting up a way for them to say, like, I might need a minute here. And I know it's not always possible, but it's helpful just to think through those things proactively, when you can. And then when distressing events do occur, because they probably will, figuring out how will you debrief and discuss that with the student. So identifying a time and space to process what happened and talk about it is really valuable. Again, if you can prepare proactively to think about that, it makes it a lot easier in the moment. It might be helpful to do it face to face. It might be helpful to walk and talk. So you don't have to look at each other when you're talking about feelings or difficult things. For some students, that feels less threatening. Maybe it's an immediate debrief. Maybe it's a little bit later. But we want to be careful that we're not letting folks isolate completely, and that we're being open as the preceptor and kind of the leader in the scenario. So timely, consistent debriefing is ideal. It's good practice to debrief with every student, not just when you see they're struggling. This is valuable for everyone, even if they don't have lasting impact, but just to talk through what's happening. If we can model grief and emotional response so that learners know they're not alone, that's really valuable. Not that we're going to fake an emotion we don't feel, but expressing that can be powerful, and allowing them to, express themselves and receive support. Also, sometimes it's important to note here, things may come up later, and it may be a month from now when the student is like feeling the impact of the experience they had. So knowing that there are resources, I'm sure your experiential contacts here will tell you resources that are available to students even beyond your rotation. So don't forget that they're a contact for you, but making sure students know they have resources, and sharing if something does unfold with your experiential team so that they can continue to support students can be great too. And then just to kind of wrap it up, I think this model is a helpful way to think about distressing events. This model is actually based on medication errors, and other things, but I think it's really helpful. So it's the erase model, which means E, we're going to expect this is going to happen and we're going to plan for it. R is recognize when it's happening. And again, if you're sending a student off to work with someone else, it might be good practice to check in and make sure there wasn't something that occurred that needed debriefing when you were away. We're going to address situations when they occur and support our learners or colleagues afterwards through that debriefing process. And then encourage discussion and training about this amongst you and your teams if you haven't already. I think that can be powerful too. I know we're butting right up to 11:30 here. I have some references too, but I'm curious what questions you have or comments or thoughts kind of in the last minute or two.
I just want to say, Kate, firstly, thank you for such a wonderful presentation. But for any of you folks who are having and precepting Western New England students, we do have resources available, of course, as does most, if not all, colleges and institutions, whether it's counseling services, whether it's therapy, you name it, for mental well-being available to those students on campus. So feel free to always reach out to us. We can give you those resources if necessary.
I think we also have them listed on core. So
That we did.
and we have 24-hour counseling for our students. So if something should happen, definitely reach out to us, but know that you have access to all the information right on CORE.
Thanks for throwing that out there. I always assume, but it's a good reminder. I put my title screen up there too. It has my contact information in case you ever want to reach out. I'm happy to answer questions or talk more about it. Like I know you got your team here that I'm sure will do the same. But I do really appreciate y'all taking time to come and hear this during your lunch hour for sure. And hopefully it will spark some conversations.
Okay, we
Excellent talk.
want
Thank you.
to thank you for sharing your knowledge and your experience and your research on this. We really, really appreciate it. As you know, it is a topic that does need to be addressed. And so we want to thank you for that. And I want to thank everyone that attended. Thank you for taking time out to come and hear and listen and join us on our Lunch and Learn. Our next Lunch and Learn will be February 14th, where we have our Assistant Dean, Kim Pesatora, presenting on No Cap, Real Ways to Motivate Gen Z Students. So we're super excited about that too.
All right. Thank you all so much.
Thank you and have a great day.
Thanks.